disease or ocular rosacea. IPL is relevant for any form of dry eye, really important. We have 18 peer-reviewed published journal articles now supporting this. So if you're wondering, is there evidence? You don't have to look at all this now. 18, if you like, randomized, double-blinded, placebo-controlled studies, we have it. And of course, if you search the literature for any injuries, ocular injuries, intraocular injuries, you won't find any. It's very safe. Most of the injuries reported in the literature are around lasers. This is light. It's not a laser. The only study that has intense pulse light is Lee et al., as you can see there. And in this case, there was some side effects such as pain, photophobia, iris atrophy. But look over here at the far right column. It occurred in patients when the safety glasses were removed. In other words, the providers mistakenly took off the safety goggles to treat the lids. When eye protection is worn, when safety goggles are worn, eye protection is worn, there are no reported intraocular injuries. We're talking about a very safe treatment. Again, we're reminding ourselves, why IPL? Also, this is some data from the US here. I don't know if it's similar, but we're seeing declining reimbursement for cataract surgery. More and more cataract surgery is worse, less and less. In the US, the price for a cataract surgery, the reimbursement is now $557 per eye. In general, we're charging around $1,200 per patient for IPL. So you can see that an IPL treatment is worth more than bilateral cataract surgery. So as we as surgeons are trying to recoup the losses from these diminishments in cataract payments, it's a great way. If you were to say to a doctor, hey, would you be interested in a treatment where you could make as much or more money than cataract surgery and not have to leave your office? A lot of people would want to at least hear what you had to say. So again, cataract surgery is becoming more important here. And we understand that we're offering premium lenses, presbyopia correcting lenses. Why shouldn't we also offer a premium kind of dry eye package? So we're certainly seeing some opportunities around this simply to drive additional revenue into our practice in addition to going to the operating rooms. This is particularly relevant for some MDs who focus solely on their role as surgeon and don't really think about their opportunity to drive revenue into their practice from something like dry eye. So with that background in mind, I want to have the discussion now about what kind of changes we can make to our practice. And again, feel free to save questions for the end. I know I went through that pretty quickly, but I really want to get to this because this is the meat of the presentation. What can we do in preparation, or what changes can we make to our practice so that we can be maximally successful with this? All right, we bought into the science, we bought the machine, we want to be successful. Well, one of the first things to do is practice philosophy. A lot of problems start with the practice having an inappropriate philosophy. And just like that quote says there, with every cataract, you at least think about, is this cataract ready for surgery? It might not be, but you at least have that thought. Are you having that thought with every dry eye patient? You really should be. You really should be. I want to look at three philosophical adjustments that you can make to your practice. Number one, it's the obstacle versus opportunity philosophy. In other words, do you and your staff and your doctors see dry eye as an obstacle or as an opportunity? Unfortunately, many doctors see it as an obstacle, and that's the first problem. This was a study that actually got published. I couldn't believe it. It surveyed doctors' attitudes all around the world for treating dry eye. They simply handed out a questionnaire to doctors and asked them to rate their attitudes. The conclusion to this published study literally stated that the interest amongst eye care professionals is relatively limited based on the fact we couldn't even get them to fill out this questionnaire. That's bad. We know this. This was a referral that I got from a doctor. It's real. It says the patient has too many complaints. All her tests are negative. The problem's all in her head and she's hopeless. So I'm referring her to you. This is the attitude that a lot of doctors have towards dry eye. So if this attitude is in your practice, well, that's the first problem. And one of the first opportunities to change how you think about this. You got to see this as an opportunity. And as you think about dry eye algorithms, where does IPL fall? Where does it fall? Well, the opportunity that you guys should be seeing is at the beginning and the end. Yeah, it's at the end. It's in patients who have tried it all. We see these folks all the time. They come into our offices. They say, I've tried the prescription drops. I've tried the tears, the plugs, and the nutraceuticals. I'm still suffering. Wouldn't it be nice to offer them a new treatment, a new approach like light? But what doctors don't realize is the opportunity is also at the opposite end. It's at the very beginning. Have you ever had a patient who you say, hey, you got dry eye? They look back at you from the very start and say, hey, doc, I don't use drops well, or I don't want to have to use drops my whole life. Great. Would you be interested in a dropless approach? So we have opportunity to discuss IPL at the beginning and the end and all sorts of places in between. But remember, you got to be thinking about opportunity. You can't look at this as an obstacle. We need to see dry eye as an opportunity and follow-up visits and treatment. That's the first thing to overcome. There's also the philosophy that I refer to as the philosophy of all versus some. How many of you have had this thought? My patients don't want to spend this kind of money. I hear it all the time. People are reluctant to purchase this because of this way of thinking, the philosophy of all. I say all versus none because we're tending to think that if all of my patients won't buy IPL, it's not for me. This treatment is not for all of your patients. That's not the metric. It's for some, and that's okay. It doesn't have to be for all of your patients for it to be for you, but people immediately go into this thinking of that one patient who said that they can't afford it. And we've had that patient, and there are some patients who can't afford this. That's okay. It's not for all, but we also have patients who don't want to spend it, and that's a different kind of patient, and that's a patient we need to approach differently. But to say my patients don't want to spend this money from a very limited data set, it's kind of like saying, hey, I've got an uncle who smoked 5 packs of cigarettes since he was 14. He's 90 years old, so smoking can't be that bad for you. Really? Again, we do have some patients who can't afford it, but most of the time we're dealing with patients who don't want to spend it, and we need to talk to them. It's not for all of your patients, it's for some. So be careful generalizing patients' financial abilities. Some patients will, some patients won't. It's intended for some. Remember, we offer premium cataract surgery, those lenses for presbyopia correction. In the US, only 15% of cataract surgeries actually use these premium lenses. 15. But despite the fact that 85% don't, we still offer it. Again, the criteria of it has to be for all my patients is the wrong philosophical criteria. The next philosophical problem is the one that it's a whole practice philosophy. It cannot be a single doctor's philosophy. I see this all the time. There's one doctor in the practice really excited about this, and that doctor becomes the champion. And that's great, and that's okay. But then all the other doctors think they don't really have to think about it anymore. While it's true that only one doctor necessarily needs to be performing it, it doesn't therefore follow that the rest of the doctors shouldn't be thinking about it. This has to be something that the practice understands, that all doctors, no matter what they do, need to be aware. They need to have the knowledge and the awareness of IPL, even if they're not actually treating it. Because if all doctors aren't thinking about it, then they're not going to refer to the practice champion. So it's something that through education, through lunch and learns, we have to make sure that everybody in the practice is on board, even if there's one doctor assigned to be the primary treater. Here's some other philosophical issues that I sometimes see. And again, ophthalmologists and optometrists tend to be a little bit different here. Ophthalmologists tend to delegate and dismiss dry eye. They delegate and dismiss. And optometrists, at least the ones I see, tend to deny, in other words, deny that they're allowed to do this treatment and defer it to others. Remember, ophthalmologists tend, unfortunately, to think of dry eye as this is kind of trivial. I'm a surgeon. I don't need to spend my time with this. And that identity of thinking oneself as a surgeon misses an opportunity to treat dry eye for sure, and misses an opportunity to drive additional revenue. You can still be a surgeon and treat dry eye as well. So there's that failure to see the financial opportunity, a failure to co-manage. And there are many ophthalmologists who no longer operate, whether they're getting older or for other reasons. What a great way to add a procedure to your practice to drive additional revenue in if you're an ophthalmologist who just doesn't operate anymore. That's really a great way. Again, optometrists, and this may be reflecting my experience in the States, get a little bit timid. Some states in the United States have given the green light and said, go ahead and do it. Others just haven't said anything. So some get a little bit nervous. There have been no cases in the United States of an optometrist being reprimanded or somehow written up for using this. It just hasn't happened. But some are a little bit timid about being the first in their area, in their state or their territory. Being the first is not a bad thing for the most part. It's a huge opportunity. If you can be the first in your area, go for it. Because one thing you definitely don't want to be is the last, okay? So being the first. I also tend to see a certain degree of caution in optometry that I don't necessarily see in ophthalmology. This is a very safe procedure. Again, it's light. It's not even a laser. And as I've often said to my colleagues in optometry here, if you aren't permitted to use light, then you can't even turn on your slit lamp exam, which we know not to be true. A wonderful, safe procedure for both ophthalmologists and optometrists, and an opportunity to co-manage. Sometimes we can set up a referral system between the two if one doesn't actually want to be the treating party. So now that we've considered philosophical adjustments that one can make to their practice, I want to now shift the conversation to another aspect, really important. This could be probably the most important thing that I see as lacking in practices that don't meet their full potential with IPL, and that's communication. It might strike you as odd, but what you say counts as much as what you do. And a lot of doctors, unfortunately, are not very effective at communicating around the treatment for this. So really, really important. And again, a lot of doctors don't think of this, but there are opportunities to say the right thing, to have effective communication before treatment, during the treatment, and after the treatment. Remember, as we think about devices in dry eye, there were a number of advantages why we think about adding devices in dry eye. Just think about it. It's drug-free, it's drop-free, it's insurance-free, which is really nice here in the States. But there are a few other intangible reasons why devices add a unique advantage. And one of them is it improves the doctor-patient relationship. It adds a bit of tangibility to the treatment. When patients have been going from doctor to doctor who throw eye drops, who throw plugs, who throw pills, it's really nice when a doctor actually lays his or her hands on a patient. That's something that doesn't happen too often. And that 5 minutes that the doctor spends with the patient doing IPL, that 5 minutes will seem like an eternity to the patient. And there's a huge intangible benefit. But if you're not a good communicator, if you're not using that little bit of time with the patients to help them understand, then you really miss an opportunity to harness that intangible benefit of the doctor-patient relationship, which is one of the reasons that you got a device in the first place, truly. As we think about communication throughout the treatment, there are two things that really, really count. Number one, manage expectations, and number two, provide reassurance. Manage expectations, provide reassurance. That has to be done at the beginning, in the middle, and at the end. And remember, typically we're doing 4 treatments. We're doing 4 treatments. So this discussion of communication is relevant before, during, and after. But reassurance about what they're going to experience, reassurance about what they are experiencing, and then reassurance about what they experience. Let me dive a little deeper into this, because I really think this reflects a huge opportunity and a huge area why some docs aren't as successful. So let's start by, how do you have effective communication about IPL before you even do this? What does that actually look like? Well, I'm going through some scenarios here. Remember, are you even thinking about this for all your patients? I said this in the beginning. If you see a dry eye patient, just like if you see a cataract patient, ask yourself, is this an appropriate patient for IPL? You got to at least ask that, consider that. That's got to start. Not just you. Are all of your providers having that thought? I don't care if they're a glaucoma specialist or retina specialist or what. Okay? Are all your doctors trained to at least think about IPL? And when you do think about IPL, what are the first words that come out of your mouth? You know, I can't tell you how important that is, because what you say, the first things you say, is going to set the course for everything else. If you bring this up in a way that is, that is comforting and compelling, you're much more likely to get where you want to go. So this is how I might bring it up. I might be very, very simple. Hey, you've got dry eye. Would you be interested in a drug-free, drop-free solution? So easy. You got dry eye. Most people, when they hear that, are going to say yes, all right? Who wouldn't at least be interested? And once they say yes, you say, great. Let me tell you a little bit more about IPL. And because you've already caught their interest with the question, at least they're going to listen to you, all right? So a great way to start. Would you be interested in a drop-free approach? Most people are at least going to say yes at that point. Let's think about communication before a little bit more here. Once a person says, yes, I'm interested in learning more, how do you describe this to patients? Because again, you can describe this well, or you can describe this poor, and if you don't describe it well, you're going to turn a lot of patients off there. Are you using comforting language that's compelling and clear? You don't want to be pressuring your patients. You want to make this appealing. Are you using the right words? What words do patients respond positively to? And you ever think about this? Some words work better than others. For example, what words do patients tend to respond positively to? How about natural light? Or how about treating the skin? What words do patients not respond positively to? How about laser procedure? That one tends to be a little more negative. Or how about a procedure to your eyes? That one doesn't work as well either. So watch what words you use. So for me, I'll say something like this. It's natural light. Light that's been filtered that allows only certain wavelengths to get through. That's absorbed by those tiny little blood vessels, shrinking up inflammation and reducing the inflammation that affects dry eyes. So real simple. You don't have to go in too much, but you want to use words that are compelling, clear, and comforting to patients.
This is probably one
of the most important steps here, and that is to define expectations. Be sure you define your expectations and goals, because if you don't define that, patients may change what they think they're expected to feel. It changes. When a patient comes in, and we know this with dry eye, people have all sorts of complaints. Make them pick one. Ask them to pick one. You really want to lock in on one complaint that they would like to see improvement, because you're going to use that as a mile marker as you move forward to refer back to that one complaint. If you don't do that, patients tend to move the goalpost a little bit. So really pick that one complaint and really make them commit to it. Also, as part of expectations, tell them what it won't do. Discuss the limitations. For example, let them know that this doesn't work right away. So here's one of my sounds like this sounds like dry eye has affected your eyes in many ways. But if you had to tell me which symptom bothers you the most, what would it be? What would it be? And that's, again, a real way important. When you want to get them to commit to this, express limitations. You know, our goal isn't to cure this. I want to let you know up front. Our goal is to reduce the frequency and severity of your flares. So right away, you're setting expectations that we're not going to get rid of dry eye altogether. We're trying to mitigate it. We're trying to reduce it to some extent. Really important. Reassurance, expectations. Also, when you think about before treatment, do you have a consent? Do you remember to consent the patient each time you see them? Which risk factors do you tend to highlight when you're discussing the consent, and do you frame these risks in a reassuring way? So when I talk about the risk, I tend to say this: all medical procedures carry some risk. The main risk of the procedure, and I pause. Patients are expecting me to say blindness. I say the main risk of the procedure, it doesn't work. Patients usually express some relief at that, okay? Because that doesn't scare them as much. And I say, you know, there's no medical procedure that works 100% of the time. So I'm letting them know, but to be honest with you, I tell them, I'm not even treating your eye, I'm treating the skin around your eye. And so there's actually very little risk to your eye itself. These are very reassuring things to let them know. Well, let them know, you know, it's possible. The greatest risk, you could go through this treatment and you might not be any better. But that's the risk of any medical procedure. That's probably the risk that I find patients I actually appreciate your honesty. And sometimes when you're honest about that up front, it actually makes a better case for moving ahead with the treatment. Here's the question: do you use diagnostics to encourage the use of IPL? If so, what do you do? Which ones? Do you use an osmolarity number? Do you show them pictures of staining? I have to say, of all the diagnostic tests out there that tends to couple with IPL the best, it's probably mybography. And that's because you're showing them an image. Patients can see dilation, distortion, dropout, which is much more effective than giving them an osmolarity number or an MMP9 number. But the question is, what do you intend to do with it? Do you intend to get before and after photos? You have to be a little bit careful with that. I think getting before photos is really a good idea, because you can say something like, your mybography clearly shows glands with dropout, distortion, dilation, atrophy. Clearly, IPL would be helpful. And they look at that picture like, wow, that looks bad. And they're much more likely to do it. But you want to warn them. You want to let them know, if you're going to use diagnostics, that you're not necessarily going to rely entirely upon the diagnostic to determine success. So if you got to the end of the treatment, for example, and the patient was feeling better, but the mammography didn't look any different, you don't want them to feel like it's a failure because we can't. So sometimes I'll say something like this, but remember, it's important to remember that we're not treating tests. We're treating you, we're treating the patient. And in dry eye, what patients see and feel might not be the same thing. Many patients will feel a lot better, and that's your goal, even if the test hasn't changed. So you can use tests, be a little bit careful, because you don't want patients to buy into the test so much so that if you can't show them a frank improvement afterwards, that it somehow undermines their sense of improvement. You gotta be a little careful with that. Here's the big question I get asked all the time. When the patient asks, is it covered by insurance? How do you handle this? How do you handle this? Do you provide perspective? What I do is I start with the price of one treatment. It's an easier starting point. You start with the price of one treatment. And I have found that many doctors have just simply become timid about talking about money with their patients. They just don't want to have this conversation. As a doctor, if you tell a patient, look, I think this is medically in your best interest, but it's not going to be covered by insurance, or it's going to be a cash payment, but it's in your best interest. When they hear that from you, when you say it confidently and you say it as their doctor, they appreciate that and they're much more likely. But a lot of doctors have become timid. We've got patients who spend money on the latest cell phone and the fastest internet. We should be okay telling patients it's okay to spend money on healthcare. Remember to distinguish between those patient types. Sometimes, and part of this, I talk about money only up to a point. I bring it up, I discuss it, and once they have specific questions about payments, then I defer to the financial counselor. But I think it's reasonable for the doctor to be the first to bring it up. And here's what I say, and again, this is what we do. I say I've got good news and bad news. The bad news is that it's not covered by insurance. But the good news is that you have a medical condition, and we're using this for a medical purpose, medical pricing. As you know, most likely can be used for aesthetic treatments. And when we do that, it can be thousands of dollars. It can be a lot more expensive. But we're using this for a medical purpose. And while you might notice some aesthetic improvement, we're doing this for a medical purpose. The price is $300 per treatment. We generally offer a package of 4, and we'll throw in a 5th one for free. So I started with $300. The number's not as frightening. We generally recommend patients purchase the package, but again, starting with a lower number psychologically tends to do well. Patients. That's a way to begin the conversation about pricing. Again, we're talking about communication. Now, what happens during treatment? This is a really important part of this as well. What happens during treatment? And there's 2 opportunities during treatment. One, it says during the follow-up visit, when a patient tells you they're better or that they're not better. But then I also mean, what are you actually saying? What words are coming out of your mouth as you're treating them? There's a huge opportunity there that doctors miss a lot. Remember, there's that intangible. So let's look a little bit about what kind of communication you can have during treatment. How do you respond, for example, when a patient reports improvement? They come back to you after treatment and say, Doc, I'm already feeling better. What do you say? Do you let that go, or do you actually say something? What do you say? How do you handle it when there's subjective sense of improvement, when they're saying they feel better, but you look at the slit lamp and they're no better at all? How do you handle that situation? Do you repeat the diagnostics again? And how would your response differ if they notice improvement, say, after 1 treatment versus after 4? What would you say differently if their improvement occurs earlier on versus later on the treatment? When a patient notices improvement after 1 treatment, which is amazing, unusual, but it happens, be excited, celebrate. Wow, it's great, already noticing improvement. Admittedly, you're a bit ahead of the curve. Make them feel exceptional. If a patient's feeling better early on, great. Make them feel exceptional, because when you create a positive emotion around this procedure, they're much more likely to maintain it. So make them feel good about that. But always provide perspective. Again, always expectations. Like I told you, reassurance and expectations. Remember, I'm really glad you're feeling better, but this is a chronic disease. You're still going to have flare-ups. You're still going to have good days and bad days. But when you do, when you have a bad day, I just don't want you to think the treatment's not working. So you're inoculating them. This is inoculation theory. You're telling them, look, I'm glad you're feeling better, but please don't give up hope if you have some bad days. That's the nature of this disease. So preemptively let them know that. How do you respond? You're in the middle of your treatments, treatments 3, treatments 4, when a patient says, Doc, I'm not feeling any better. Do you have the patient specifically tell you what's not better? Really important. And do you remind them of that one chief complaint you made them commit to? Because for all you know, they've changed. Now they're talking about something else, and they forgot what they told you bothered them the most at the beginning. Do you repeat the diagnostics again? And how can you use the slit lamp exam to reassure? How can you use the slit lamp exam to sort? And again, letting patients know about the sign-symptom disconnect is a great way to help them with this. It would help them with this. Because again, a lot of times, again, you know, there will be objective signs of improvement. So what I'll say to patients is, you know, it's not unusual to not see changes yet. Oftentimes, it takes several treatments to notice improvement, and some patients it takes the entire course. So it's not unusual to not say anything at first. We're remodeling the microvasculature. It takes some time. So of course, use time. Also, remember, if you see objective improvement and they're not having subjective improvement, let them know. Use your objective signs of improvement to counteract their subjective lack of improvement. Remember, there's the patient perspective and there's the physician perspective. Sometimes we need to give the patients the physician's perspective. So let them know that, hey, I'm seeing some improvement in your tear film, for example. The good news is your tear film's coating the eye more evenly and the tears are not breaking up as quickly. In dry eye, I can oftentimes see changes before you can feel them, making great progress. So you're reminding them of the sign-symptom disconnect, telling them that you see signs of improvement, which is encouraging. Now, what happens when a patient comes in who was doing great, and then they come in a couple of visits later and say, Doc, I'm not doing well anymore. How do you handle that? Again, do you clarify whether it's the same symptom that you made them commit to? Do you ask them to compare the relativity? Really important. So they might say to you, yeah, my first chief complaint to you was foreign body sensation. And yeah, I am still feeling it, but I guess, you know what? I guess that is a little bit better. Remind them of that chief complaint. Use the slip to remind them of the disconnect again. And if they're having some symptoms, they are getting worse, don't hesitate to give them some bridging treatments. If you need to give them a short-term steroid, you can do that to boost the effect of the treatment. So I might say something like this: don't be discouraged. Like we discussed, this is a chronic disease. We're giving perspective, we're giving reassurance. Our goal wasn't to eliminate flare-ups. We know that's a part of this disease. Our goal is to reduce the frequency and to reduce the severity. And ask them about that symptom. On a scale of 1 to 10, I like these scales, if your initial symptom was an 8, how would you rate your symptoms now? That's a really good way to do it because it gives you some objective perspective. So if they say, oh, well, I guess it's a 7, you can say, great, I see you're making some progress. If they say it's an 8, you can say, well, I'm glad you know, we're working with this. I'm glad you haven't gotten worse. If they say it's a 9, you might say, well, all right, let's add a steroid to boost the effect of this treatment. And if they say to you, it's a 10, well, patients who say 10, there's usually an emotional quality to that, and I wouldn't argue with them. The folks who say that, just comfort them, agree with them, and tell them we're going to continue to work on it. Okay, validate it. The 10 patients are usually having a bit of an emotional reaction. It's important to validate that. Also, are you the one doing the treatment? Don't delegate this. Remember, we did this for the doctor-patient interaction. What do you say while you actually treat them? Have you considered reviewing the rationale each time you treat them? And when performing follow-up treatments, do you specifically reference their point of concern? If you're making adjustments, tell them about it. So when I'm treating them, I'm not talking about their vacation. I tell them, I remind them why we're doing this, because we're reinforcing the rationale. And if I've made a change, I let them know. Based on what you've said, I've increased the power. Let them know you're hearing it. If they're having issues, let them know you're making adjustments. Be deliberate about it. And finally, in the communication section, I want to talk about what do you say after treatment. This is really important too. If you have a patient who's very happy, you just let it go? No, that's a missed opportunity if you do. Do you validate them? Do you still recommend follow-up treatment and give perspective? Do you remind them? Do you give them expectations? You can still have flare-ups, but it's not a sign of failure. And what do you do? What do you say if they say they feel better, but they don't look any better? Again, I oftentimes say, look, it's amazing. Your results are amazing. You've come such a long way. And we've treated the root cause, and you can expect lasting results. Remember, when you validate positive experience, okay, when you validate positive experience, it exponentially impresses and exponentially increases the patient's positive feelings about this treatment. When your perspective matches the patient's, very, very effective there. But always gives perspective. You know, you're doing better, but you can still expect flare-ups. You don't want them to think it's a failure, right? How do you handle the completely dissatisfied patient? One who just says it didn't work after treatment. They're really frustrated. Again, did you remind them of their initial complaints? Can you talk about some objective improvement? Acknowledge their disappointment, okay? Have you found something positive to say? Always remember perspective. So sometimes what I'll say in these situations is I'll remind them, look, admittedly, some patients experience more improvement than others. I've seen some improvement on exam, and I'm glad we've accomplished that. So that this is the patient who's gotten all the way through and is frustrated. Sometimes you can say, at a minimum, I think you would probably be a lot worse right now if we hadn't done it. You have a difficult case of dry eye. I want you to feel reassured that at least we've left no stone unturned. And sometimes I just say, look, just because you don't notice a treatment's not working, it doesn't mean it's not working. What does working mean? Let's face it, most people are not aware that fluoride in their toothpaste works either, but it doesn't mean that it's not. It doesn't mean that it's not. So sometimes we need to give patients a little bit of perspective. Okay, I spent a lot of time on communication because it's very important. Again, we're talking about adjustments we can make to our practice to be maximally successful with IPL. We've talked about improving practice philosophy. We've talked about communication. Now I want to talk about technique, because a lot of doctors say, is there something I should be doing differently in how I actually treat my patients? Remember, the pathophysiologic basis is the same for all 4 eyelids, yet most doctors just treat the lower. Why are we just treating half? First of all, most importantly, simplicity. Don't forget about simplicity. That refers to, that's why you got this. The treatment, setup, scheduling, simple. This is simple treatment. You got this machine because it's not only effective, but it's efficient. This shouldn't take a lot of time. It takes me 5 minutes, all right? So your scheduling should be done simply. It should not create chaos. Your setup should be simple, and your settings can. What do I mean? Tips for scheduling. This is really important. I generally perform a medical exam on all my patients. Diagnose them with dry eye. In the US, we charge an insurance medical visit for the first exam and identify them with dry eye. I don't typically begin treatments at that visit because that'll wreak havoc in my schedule. I'm not set up for that. So I will tell them, unless they've traveled from a far distance, then otherwise, they schedule their treatment. They schedule treatments, usually a package of 4, right? They schedule them, but they make payment at the time of scheduling, all right? When they come in, you don't need to block off times in your schedule for this. They can fit in right between your other patients. That's the beauty of it too. Be flexible. We generally recommend a spacing of 4 weeks, but if patient's traveling or has something, you can do it anywhere between 2 and 6 weeks. Make this easy for your patients. It doesn't have to be strictly 4 weeks. Make it easy for your practice schedule. The actual setup is simple. My technician turns the machine on. I walk in. My settings are already on. All I need are gloves, a numbing drop, my shields, gel, and tissues. All right? The settings are already there. There's nothing more to do. If you're using metal corneal shields, as I'll explain in a moment, it don't need to be autoclaved. This is not a sterile procedure. Keep them clean. Wash them with alcohol or soap and water. And for me, in terms of my treatment settings, I really don't change much at all. As you can see on this grid here, most settings are the same. If you look at skin types 1 through 3, I have to admit to you, I actually use the same fluents. I use 16 millijoules per centimeter squared for all my patients who are 1 through 3. So I actually change very little. I find that the settings work well for most patients, unless they have very dark pigmentation. And that's a different question. You have to be very careful with that. With skin types 1 through 3, my settings are the same. Simplicity, simplicity. When you think about technique, you can think about 2 options, all right? There's a basic technique, which most doctors start with, and then you have a more advanced technique. And the reason I think it's useful to think of it this way is because if you start with the basic technique and you want to get better results, or you don't think you're getting complete results, it's nice to have another option to go to. The basic technique is the one that got popularized by Dr. Torius. It works very well, and it's what most start with. The doctor performs it. You put the adhesive shields, the gel, and you treat from tragus to tragus and the lower lid, but only the lower. What I've been doing since 2010 is I actually use a metal corneal shield. I put it in between the eyelids, and that allows me to treat the upper and the lower lid. So I just treat around the eye. I get very close to the eyelid margin, and I use the smaller light guide. I'm using the small light guide so I can get around the contours of the eyelid. And I do both eyelids. Like I said, why would you only want to treat half the eyelids? But oftentimes, people start with the basic treatment, the first treatment. That way, if you don't get success, you have somewhere to go. You don't want to start at the ceiling, because then where are you going to go from there? So 2 techniques. Also, this comes up sometimes. Do you have to express the meibomian glands? Remember, you got this for efficiency and effectiveness. It's optional. You don't have to. Reasons to perform it. If a patient says to you, I want it, well, then do it. If they've had it somewhere else and they say it's helped them, do it. If you believe in it, do it. But remember, there were 4 mechanisms of action, and only one of them had anything to do with the meibomian gland, the warming, and it's probably the least important. I am careful with it. I generally don't perform it because that kind of pressure can traumatize the glands and sometimes induce inflammation and pain. So while I express the glands after treatment, I do it diagnostically, just a small sampling to see whether the meibomian's consistency is improving. But I don't do it therapeutically. It's not necessary. The treatment works well enough. Remember, you don't even need meibomian gland disease to see success with this. Also, I sometimes get this question. I already have LipiFlow, or I'm thinking about the two. How do I use them together? Well, or can I? Remember, the two devices are not competitive. They can be used complementary. They can if you have both. In an ideal world, patients would get both. But if you're choosing between one and the other, how do you understand the main differences? In a device like LipiFlow, you're treating the downstream consequences. Inflammation has created meibomian gland dysfunction, but you're not treating the reason the glands got backed up. All right? With intense pulse light, you're treating the upstream inflammatory cause. With intermittent thermal pulsation and heat, you're limited to evaporative dry eye, but like I said, with intense pulse light, you're treating both evaporative and aqueous forms. There are disposables with LipiFlow. There are no disposables with the Optimal IPL. You get one shot with the LipiFlow. With IPL, you have multiple visits to manage expectations and reassurance. With thermal pulsation with LipiFlow, it's a long lump sum payment. Here, patients can pay as they go if they like, so it offers a little more flexibility. And again, I'm the one performing this. So the nice thing about that is the doctor's performing it, and that's a good thing. That's a good thing. With LipiFlow, it tends to be performed by a technician. Who do you think is going to do a better job of reassuring the patient? You or your technician? Who's going to do a better job of setting expectations? It's a great opportunity, actually, to be the doctor performing this. That's performance. The final suggestion that I have for you, and then I'll be happy to take some questions. The final suggestion, in order to prepare your practice or improve your practice, is to consider your marketing opportunities. Remember, we're considering how do we make adjustments to our practice to be maximally successful. Your best marketing strategy is the awareness that the patients are already there. Again, I can't tell you how many times I hear doctors blaming. They say, I thought the company would give me more marketing support. You know, your marketing's already there. Your patients are already there. Lumenis actually does a wonderful job of supporting practices through social media, through print material, etc. Your best marketing option is the patients who are sitting right in front of you. They're already there. Even if you do nothing, they will come. They are there. It's just time for you to notice. This gets back to what I said in the beginning. Obstacle versus opportunity. Are all your doctors thinking about this? Because if they're not seeing opportunity and they're not all thinking about this, then you're going to miss your greatest marketing opportunity, which is simply to remember you got one of the most common diseases there is in your practice every day, and they're there even if you did nothing. You just got to remember to talk about it. So when you think about a marketing machine for simplicity, you can think about these three components. You got the practice, the providers, and patients. And in between the practice and patients are emails and electronic correspondence. Again, the doctors and the practice education is really important so that everybody is aware, so that everybody has knowledge. But the greatest opportunity is right there. It's that conversation that happens between you and the patient, and it doesn't have to take long. You've got dry eye. Would you be interested in a drop-free, drug-free approach? You've got dry eye. Would you be interested in a natural treatment? There it is. And these patients are sitting there right in front of you. Don't forget to ask, all right? So often, docs forget they have a new tool. When you're a hammer, everything looks like a nail. If all you got is your traditional remedies, everything looks like an eye drop. When you've got IPL, it's not all about drops. Don't forget, every day is a marketing opportunity. Set a goal. Say, today, I'm going to at least try to remember to bring up IPL with 5 patients more than I typically do. Just set yourself a goal to bring it up. I'm not saying you're all going to do it. Just remember to ask, okay? One of the greatest limitations to success with IPL is habit. Habit thwarts progress. You've got to get out of habits and routines. And a lot of times habits and routines don't include mentioning IPL. So be sure to bring that up. Watch out for routine. Another thing that comes up sometimes, which deserves a little bit of attention, is bundling. And I get it. We bring up bundling around cataract surgery because, let's face it, we have focused a lot on the value of treating dry eye around cataract surgery, both before cataract surgery because it can improve the accuracy of the measurements, and afterwards. because we have patients who've invested a lot in their cataract surgery and are having refractive disappointment. And a lot of times we can attribute to the ocular surface. So we know that there's a value for treating dry eye around cataract surgery. So many people are tempted to bundle it. It can work. In my experience, you gotta be a little careful with this. There are some areas of the United States where you can bundle this in there and charge more or charge a premium lens and IPL, but it gets kind of expensive. You've got to be a little bit careful about this. So let's think about this. What are the advantages and disadvantages for bundling IPL with cataract surgery? Well, the reason I avoid it is a lot of times if you add on another cost, patients can get a little overwhelmed with this, and it can be a little unseemly to keep adding on costs. And a lot of times when you do that, patients can be turned off, and you can lose both an IPL patient and a cataract patient if it seems like you're adding too much on. So I had a doctor say, well, if I need 4 treatments and I have a patient who's ready for cataract surgery, they're not going to want to wait 4 months for the surgery. That's right. So my suggestion is don't wait till the cataract is ready. Start discussing IPL 6 months or a year before you anticipate the surgery, before it being visually significant. That's when you should be having the conversation. You've got a cataract. I think we'll need to do it in about 6 months or a year. This will be a great time to think about the ocular surface. So think of it as a preparatory phase. But still, some practices do have success with it. If you're going to bundle it, do not bundle it as an add-on. Instead, have it be one procedure, a premium cataract procedure that includes premium lenses and IPL. Make it appear like one thing instead of additional add-ons here and there. And I also would encourage you, if you do want to bundle it, to consider using IPL, not necessarily before, but after. Why do I say that? Because we do have some patients who come out of perfect cataract surgery but are still disappointed. I find a lot of times it's reassuring to patients who are disappointed, who maybe are 20/30 instead of 20/20, to identify the ocular surface and say, guess what? We can do this treatment to help you. So if it's already bundled in, consider bundling it so that it's afterwards, so patients continue or to be reassured that the visual results can improve. All right, simplicity sells and works. Remember, be simple. Simple email blasts work great. Got dry eye? Tired of drops? Come in and learn. Simplicity. You send out an email like that, you're going to get a response. You're going to get a response. Also, you can get creative with your marketing. There are doctors out there who don't know about this necessarily, who can refer you patients. Dermatologists, they're already comfortable with IPL. They're already using it for the face, but they don't want to go anywhere near the eye. They would love to send these patients to you. It's not competitive, and it would complement what they're doing. Also, in the United States, we have a concierge concept. We have some doctors who just don't take insurance. And if you have this structure where you are, you can consider working with doctors like that. Again, they might have a particular brand of care, and an IPL procedure might be appealing to them because it's state-of-the-art, and they want to offer their primary care patients a state-of-the-art experience, even with their specialists. And finally, remember the opportunity to co-manage between MDs and ODs. It can go in either direction. Sometimes you have an MD who doesn't want to treat dry eye. Sometimes you have an OD who doesn't want to do IPL. Again, having one doctor do the perioperative management, diagnosing before, evaluating after, and one doctor doing the treatment creates a co-management strategy where in some cases you can even share in the revenues. So in the end here, I want to give you a checklist. Again, the point of this conversation today was to talk about the next phase of IPL. We know you can, the science works. How do you actually be successful? And I've given you 4 broad suggestions of things you can do to change yourself, your practice, your doctors to become more successful. So take a look at this checklist here, and then I'll get to some questions here. Remember, are all of your doctors thinking about IPL for every patient? It's got to be a thought at least, even if they don't get it. Have you accepted that IPL doesn't need to be for all of your patients, that it just can be for some? Are you remembering to discuss IPL when you see that dry eye patient who just doesn't seem to get better after traditional therapy, which we have a lot of? Or are you discussing it with the patient who tells you from the beginning that they don't use drops well, something we also see a lot of? Are you being deliberate about expectations and goals and reassurance? Deliberate. Have you become less timid in recommending a medically justified cash-based service? It's okay. Patients are spending money on lots of things. They can spend money on their health care. Are you reassuring patients? Are you treating the upper and lower eyelids to get the maximal results? Are you maximizing simple messaging to your patients? And are you considering local doctors around you? These are some of the key things that I hope you take away from this. Again, like I said in the beginning, IPL has come a long way from anecdote to science, and now it is ready to become success. What you do in your practice can really make the difference between success with IPL and just having another treatment option. You have the opportunity with some small adjustments in your practice. You can take what has been the best kept secret in eye care and make it one of the best known commodities that you offer in your practice. Very exciting. I hope this has been helpful for you. I'm going to try to get to some of these questions here. Bea, are you there?
Thank you, Dr. Adler. Amazing presentation. Yes, I'm here. I saw that we have 2 questions.
Can you read the questions for me? I'm having a little trouble seeing them here.
The first question is if you use any drop after the IPL procedure. I assume it.
Excellent. So if a patient comes in and they're already using drops, generally we'll continue them on it, although I have to admit many patients become less dependent on their drops afterwards. If it's a patient's specific goal to get off of a drop, we can look towards that. And again, that's one of the things you wanted to define in the beginning. But I oftentimes tell patients, look, this is a complement to your treatment. Dry eye is a multifactorial disease. It requires a comprehensive approach. So it's oftentimes okay to stay on Restasis or Xiidra or Cequa or artificial tear, that's okay. If the question was, do I add a drop? Do I add something that they weren't on before? Not typically, but occasionally, like I said, if a patient comes in, maybe they were doing well after their first treatment and they come in for the second or third and they're not, sometimes I'll give them a short course of a steroid just to boost the effect a little bit. But in general, we're using IPL as a complement to the treatment they already have. Although many times patients will be able to stop their tears. You see that all the time. Great question. What's another question, Bea?
Next one is, how do you manage your workflow? Do you do the IPL treatment when patients say yes after the diagnosis exam, or do you schedule them for, do you have specific IPL treatment days to treat them with IPL?
Yeah, and again, a really important question. So for me, for the most part, I do a comprehensive medical exam, diagnose dry eye, talk about IPL, and then we schedule for another day. Sometimes we'll schedule all the treatments. And what that does is it prevents overload. If you're recommending IPL to a lot of people in a day and they want their first treatment, you're gonna run into scheduling problems, and that's very stressful. So to avoid that, I have them come back. Unless I have a patient traveling a great distance to come in, they come in for IPL. Well, sure, you make an exception here and there, but for the most part, I find it's better to bring them back. And like I said, you don't need to block out portions of your schedule for IPL treatments. You really don't. They can fit in. It's a 15-minute exam for me. The treatment's actually 5 minutes. I talk to them a little bit. So one of the beautiful things about IPL is that it interdigitates. It fits in really well between your other patients without having to rearrange your day.
Yes, I have a question. Can we do the IPL more than 8 or 10 times continuously?
Yeah, another really good question. So I tell patients also that you might need a retreatment. It's possible. While most of the time patients don't, most of the time you don't after the complete treatment. There are some patients who maybe a year later need a booster. They might need one treatment. They might need a whole series. I do tell them that it's possible you might need a retreatment, although some don't. There is no restrictions on how many you can do. I have one patient that comes to mind who always feels so good after their treatment that she literally comes in once a month for this treatment. It's like a spa treatment. And she comes in and once a month we do it. There's no risk. I wouldn't say it's necessary to do it all that much, but if a patient requests it, it's absolutely okay to treat more than 4. And I typically give them some expectation that we might need to retreat in a year.
And sometimes we find the really, really bad MGD and have tried more than 10, 12, or 15 continuously. Have you tried that one? And any side effect on that point?
No, I mean, in a person with really bad meibomian gland disease, there's no harm in continuing to use it. Obviously, you might need to consider some other treatments as well in those folks. And, in those cases, you might need to look toward expression. I'm not doing IPL treatment on a regular basis at all. And for some people with really bad disease, I can understand why you would do that.
And for the upper lid and lower lid treatment, have you ever got the patient that lost the hair from the treatment?
Lash loss. No, I can think of one person I know that did at another office, and it grew back. It doesn't happen as often as you might think. Technically speaking, the wavelength of light does not maximally absorb by melanin. I used a small light guide. That's my preference because I feel like I have more precise control. I can see the location better when I'm using the small light guide, and I go right up to the lower lid margin. But I can see I'm not on the lashes, so that's an advantage of using the smaller tip, so that you can avoid it. But I actually haven't had that. Sometimes you can get a little plume, like a little smoke, if it does. But it oftentimes does. I have not had a case of significant lash loss. And in the case that I'm aware of, it grew back.
Right. And last question, in your current practice, you combine the Toyo's formula and upper and lower lid at the same time, or you choose the one of them to maximize the benefit?
Yeah, I always treat the upper and lower lid. I always have. I mean, honestly, I've been doing this since January of 2010, and I just never understood why I wouldn't. Obviously, I use a corneal shield to protect the eye between the upper lid for obvious reasons. But me personally, and again, I know I described two techniques. You can certainly start with just the lower lids, and many people do get relief with that. But from a pathophysiologic perspective, I've never understood why I would not treat the upper lid. So I've always done it, and I always use that. And I only do the lids. I do the lower lid, the upper lid, and the side of the nose.
Right, and for the upper lid and lower lid, you do the 3 shot or 4 shot. I know you do 2 pass, right? And 3 or 4.
Triple shot, two passes, triple pass. 2 passes, triple shot. Yeah.
Right.
2 passes,
right.
Shot. Yeah.
Have you ever got any serious complication for the past many years?
No, I mean, I've had no complications, quite frankly, none. I'm not embellishing. It's a true story. For 10 years that I've been doing this, and I haven't heard of any. And again, when you search the literature, there's no reports when proper eye protections were. It's really safe. It truly has been one of the best kept secrets in eye care. But I have not had that.
Thank you. Thank you.
Well,
thank you very much.
Question.
I have 2 more questions. If you can tell us more about the Interpulp eye protector used when you're treating both lids.
So I use a metal corneal shield. They're readily available. If you search online, you can find them. They're in most medical catalogs. It looks like a contact lens, but it's metal, and it has a little tab to allow you to insert and remove it easily. I get the small size for ease of insertion and removal. I put a drop of proparacaine. I do one eye at a time, only because I've had some patients who get claustrophobic if they have a metal shield in both eyes. It's very comfortable. Never had a corneal abrasion. Just a drop of proparacaine is all you need. And like I also said, it does not require autoclave. It does not have to be sterile. You can clean them in between treatments.
Thank you. And last question is, if you are still doing IPL during the COVID-19 pandemic, and what kind of options are you using?
My office is not open. So unfortunately, I am not able to get into the office right now. We are hopefully opening soon. So not treating, but I like the question because what it brings up is, what are we going to see when we get back to full speed? We've got a lot of patients, at least in the US, who are not coming in for their routine care. We've got a lot of folks who are just uncomfortable coming in, leaving the house. And so we can anticipate seeing a lot of worse dry eye when things get back to normal. So while I'm not in there right now, it's a valid and very relevant question because there are a lot of people at home right now neglecting their ocular health, neglecting their ocular surface. They haven't refilled their prescriptions. They're not using the drops. So we need to be ready for the consequences of this quarantine when a lot of folks have been neglecting their care. But unfortunately, all I can do is just talk to folks on the phone and provide prescription medications at this time.
Thank you. I have one question. Why is IPL effective for aqueous deficiency? Is it because of inflammation?
That's the main reason. It's like we use cyclosporin, fetograst, anti-inflammatory treatments are beneficial in aqueous forms as well. We know this. And if you look at the American Journal of Ophthalmology, November 2017 is a great article looking at specific inflammatory markers before and after IPL treatment. They were quantified. Interleukin 6 and interleukin 16 were quantified before treatment, at 4 weeks, and at 12 weeks. And you can see statistically significant decreases in these interleukins as well as in MMP9. So the anti-inflammatory effects of IPL can be understood as one of the reasons why it can be effective in aqueous deficient forms of dry eye as well. Of course, the improvement in cellular energy metabolism is beneficial in any form of dry eye as well. By improving ATP production, you improve cellular functions such as collagen synthesis and fibroblasts and motility of immunomodulatory cells. So the energy effects are relevant also in both aqueous deficient and evaporative forms. And even Demodex, like I mentioned to you, while it can contribute to inflammation, so it can understand the role of IPL in a broad class of patients with dry eye disease, not simply evaporative forms.
Any other question?
For the patient that you always provide the IPL, do you still provide the systemic doxycycline or vibramycin?
Before and after treatment, yes. Again, you have to be a little careful with photosensitizing medications. In other words, the doxycycline, in theory, can sensitize the skin, along with retin-A's and such, tetracycline. So if a patient is on a doxycycline, I generally have them stop it about 2 weeks before the treatment because of the light sensitivity issue. But after treatment, after completing IPL, if they still need it, absolutely. And they can use it for a couple weeks in between treatments too. I generally have them stop, and it's very conservative. I haven't had any issues. I haven't heard of anybody who has either. But if they're on those treatments, I have them stop it about 2 weeks before the actual IPL procedure.
In some case of that I have tried IPL for 4, 5, 6 times or 8 times, most of the clinicals have been improved so much. But in some cases, I think about 30–40% for when we do lipid view check every visit, sometimes I can see that the lipid view thickness, lipid thickness is decreased and not related, improved by the clinical improvement. Sometimes the finding not related parallelly. Do you have any idea why in some cases the clinical is so good, but the lipid line is so thin?
Yeah, that's dry eye in a nutshell. That's ocular surface disease. We have that sign-symptom disconnect, which really makes this disease so difficult. So again, a lot of times you can have a patient really bad meibomian gland disease, right, and who feels fine, and then you can have a patient who's miserable with normal appearing lids. We know this. This is the challenge of the disease. The signs and symptoms do not correlate well in this condition, and there's lots of reasons for that we can come up with. But that's why I'm a little bit careful with diagnostics, because you don't want patients to invest too much in those images. It's great when it shows improvement, but again, just because the diagnostic does not show improvement, it doesn't mean the treatment hasn't worked. And that's a really important point. And sometimes when a doctor says something's worked or doesn't work, it's very important to define, what do you mean by worked? I would say to you that most doctors would agree, if you have a patient who's symptomatic, you treat them and they're no longer symptomatic, that's a success, particularly in mild to moderate disease. If you make a patient happy, if you make a patient feel better, that's probably the most important aspect. In fact, that's been borne out. The one global indicator, the one indicator that most doctors look to as a gauge of success in dry eye is symptoms, more so than signs. So there's a number of reasons why signs and symptoms don't correlate in dry eye, but you do not need to be discouraged if your objective tests do not match the patient's subjective experience. That's very normal.
Thank you, Dr. Adler.
You're welcome.
For any other question, all the attendees can write you an email. If
yes.
Any additional question?
Last question, would you provide the MyBoom expression every time immediately after the IPL?
No, I don't. And again, as I mentioned, I would say it's optional. If you have a patient who wants it, a patient who asks for it, or has done well with it, great, go ahead and do it. But I don't think you need it. Again, because IPL works through mechanisms that don't even involve the meibomian gland, and because manual expression can, in some cases, induce inflammation and induce pain. I'll do it gently, and I'll do it in small areas as a diagnostic attempt to see whether the meibum has improved, but I don't think it's required therapeutically. I think the mechanisms of action work well enough that that's not absolutely necessary. It's not, and quite frankly, I rarely do it, and I've been having success for 10 years with it, so it's optional. If a patient comes in saying, I want it, well, of course, then we can do it. But I don't think medical.
Right, thank you.
Sure.
I think we have clarified any doubt and replied to any question. So all the attendees who have any additional question can write either to Dr. Adler or to Luminis Vision, and we are happy to support. Dr. Adler, do you want to add anything else?
No, thank you. Thank you very much for this opportunity. I've enjoyed chatting with the group today. Thank
you very much for this amazing presentation, and thanks to all the attendees for joining us. Have a nice afternoon, and have a nice.
Very good. Thank you.
Thank you very much.